هو انا بس هاخد سؤال قبل ما ابتدي. كم واحد من حضراتكم استخدم الالترا فلتريشن كسولوشن لحالات الريفراكتوري هارت فيلير؟ جاست ريز. مفيش حد ولا واحد؟ واحد بس، 2، 3، 4 فقط من الحاضرين استخدموا الالترا فلتريشن از سولوشن. اتس اوكي. نبتدي الجورني بتاعتنا. First of all, this is the epidemiology of the heart failure. Heart failure is a major health problem resulting in high morbidity and mortality rate, and the major cost driver of heart failure is the high incidence of hospitalization. Refractory heart failure, about 90% of 1 million heart failure hospitalization are due to volume overload. 20 to 30% of patients develop diuretic resistance. Escalating doses of diuretics leading to possible electrolyte and renal derangements and more frequent hospitalization. So our target of patients are patients of a stage D refractory end-stage heart failure. Hospitalization for heart failure are increasing with time, both for men and women. From the ADHERE registry, the most admitted patients with volume overloaded come in form of any type of dyspnea, about 90%, pulmonary congestion 75%, RELS in 60%, dyspnea at rest in 35%, and peripheral edema in 65%. Over 90% of all of these patients are due to volume overload, and the majority of these patients have failed treatment with the oral diuretics. So we should remember the cardiorenal syndrome of heart failure. We start with use of diuretic therapy, which lead to neurohormonal activation and diminished renal blood flow with decreased renal perfusion. Then renal impairment started with development of diuretic and natriuretic resistance, which result in increased morbidity and mortality. The most common intravenous use in our ICUs is IV diuretic. About 88% use intravenous diuretics. So what is the definition of diuretic resistance? We can describe it as a clinical state in which a diuretic response is diminished or lost because the therapeutic goal of relief from edema has not been reached. It's about 20 to 30% of our heart failure patients. We have two types. The braking phenomenon, which is a decrease in the response of a diuretic after the first dose has been administered, and the long-term tolerance. This is due to tubular hypertrophy to compensate for salt loss. I think tubular hypertrophy and salt loss from the first lecture we have a look. What are the causes? The decreased renal function and distal sodium delivery, variability in diuretic absorption, activation of RES and SNS, drugs and diet, especially high sodium content, non-compliance with medication, and infrequent dosing. How to manage a diuretic-resistant new heart failure patient? First, you should restrict daily fluid intake, and you should restrict daily salt intake. Avoid the use of non-steroidal anti-inflammatory drugs. You can institute and arbitrate ACE inhibitors or ARBs. And about the diuretics, you can give short-acting loop diuretic orally in several divided doses and increasing doses. You can give it as bolus or continuous infusion. You can use a sequential nephron blockade, so combination of loop diuretic and thiazide diuretic. You can add some doses of spironolactone, and sometimes you can use acetazolamide. And despite the use of all of these diuretics, in 90% of patients, there is 20% of weight gain on discharge. So what are the options to treat heart failure properly? Ultrafiltration, it allows for production of plasma water from the whole blood across a semi-permeable membrane in response to transmembrane pressure gradient. And the ultrafiltrate is isotonic to plasma. What is the story of ultrafiltration? Just to remember, it started in 1949. The ultrafiltration compared to the loop diuretic citrate is isotonic to plasma, and the diuresis with loop diuretics is virtually always hypotonic to plasma. Ultrafiltration removes more sodium than diuretic therapy with no electrolyte disturbances, and it decreases the extracellular fluid volume more than a comparable volume of the diuretic-induced fluid loss. And this is about the mechanism. A transmembrane pressure generated by the device allows for the formation of ultrafiltrate via convective tissue. The fluid removal by ultrafiltration, it will remove the fluid. At the same time, the transient removal of the fluid elicits compensatory mechanisms termed as plasma or intravascular refill, aimed at minimizing this reduction. What is the relation between ultrafiltration and renal function? All of papers or studies documented that it is safe and not affect the renal function. What are the possible contraindications to go with your patient for ultrafiltration? If there is inadequate venous access, hypotension, hypercoagulable state, patient with end stage who need for hemodialysis, and patients who are already responsive to diuretics, why to go to ultrafiltration? If we take the decision to send our patient to ultrafiltration, we have to consider 3 clinical decisions: the volume to be removed, the rate of removal, and anticoagulation therapy. What are the positions in clinical trials? First, the trial is safe trial. It studied how can I go peripherally to do ultrafiltration instead of central, and this trial concludes that rapid removal of the extracellular and intravascular fluid volume excess can be safely achieved via peripherally inserted ultrafiltration without need for the central venous catheter placement as previously documented. The rapid congestive heart failure trial, it compares single 8-hour ultrafiltration intervention with usual diuretic statins. It shows that there is more fluid removal through 48 hours using ultrafiltration compared to the usual care, which is significant. And the conclusion that ultrafiltration is superior to diuretic strategies in salt and water removal. It is safe in a variety of clinical sites, and there is no clinical justification to delay ultrafiltration therapy until diuretics fail. This is the rapid trial conclusion. The Euphoria trial shows that there is a primary efficacy endpoint with resolution of signs and symptoms of fluid overload permitting discharge in less than 3 days. And the secondary safety point is without hypotension, symptomatic renal insufficiency, or adverse event. The conclusion that early ultrafiltration in patients with volume overload and diuretic resistance again can permit the discharge of 60% of high-risk acute decompensated heart failure within 3 days from the hospital. And this is treatment strategy using ultrafiltration early in patients with volume overload and evidence of diuretic resistance result in reduction of the length of stay and improvement of the clinical results. So the improvement of clinical stays, not only for the short term, it maintained for 30 to 80 days following the hospitalization. And the Unload trial, this is done for comparison of early ultrafiltration alone versus IV diuretics and its effect on the weight loss, symptoms, and hospitalization of hypervolemic heart failure patients. The efficacy point with weight loss at 48 hours and Disney score. And the conclusion that early ultrafiltration produces greater weight loss than IV diuretics without changes in renal function, and use of early ultrafiltration strategy reduces 90-day percentage of patient number of heart failure rehospitalization and days of rehospitalization each time. And emergency department and unscheduled office office visits will be reduced subsequently. So, the therapeutic goals for acute decompensated heart failure is to achieve euvolemia status. Persistent symptoms at discharge in a larger fraction of patients admitted with acute congestive heart failure. We say that 51% discharged asymptomatic, but 39% discharged improved but still symptomatic. So what is the next one? For this is 50% of this patient discharged improving but still symptomatic. And this is no problem to go with some symptoms or not. Let us to see what are the position in the guideline. In the American College and American Heart Association, in general, please, mobiles please. I'm waiting with you. اسمع معك للآخر. شكرا. لأنه he insists. Case insists. Okay, I go with myself. Management of fluid status according to the American guidelines. In general, patients should not be discharged from the hospital until a stable and effective diuretic regime is established, and ideally until euvolemia status is achieved. What about patients discharged without achieving this goal? Patients who are sent home before these goals are not reached are at high risk of recurrence of fluid retention and early readmission, because unresolved edema may itself attenuate the response to diuretics, so readmission, rehospitalization, volume reaccumulation. Current options are not achieving the standard of care. Ultrafiltration may be needed to achieve adequate control of fluid retention. The use of such mechanical methods of fluid removal can produce clinical benefits in patients with diuretic-resistant heart failure and may restore the responsiveness to conventional doses of loop diuretics. Not only achieve euvolemia, but subsequently the response to diuretics will be improved dramatically. I'm sorry, I'll go back. What about Heart Failure Society guidelines? When congestion fails to improve response to diuretic therapy, the following options should be considered, and the fifth option is the use of ultrafiltration may be considered even the strength of evidence is C. But this fifth option if all previous measures failed to achieve euvolemia status. Heart failure management will not become easier in the future. Every time we develop more techniques, more improvements, but still heart failure is a major problem and the result is not satisfactory. So this is an example of some machine used for ultrafiltration. It is called Aquadex, for example. It is advanced form of ultrafiltration. We can use it as inpatient or outpatient setting. We can go access with peripheral or central access. This is a diverse physician prescription. This is a highly automated operation with no clinical significant impact on electrolyte balance, blood pressure, or the heart rate. This machine can be used for temporary up to 8-hour ultrafiltration and can go outpatient, and for or extended longer than 8 hours. There is a low blood flow, 10 to 40 milli per minute, low blood volume, 33 milli, precise fluid removal rates from 10 up to 500 milli per hour. This quick and easy setup is in 10 minutes, highly automated operation, one acquired setting. What do you need for this? Transportable console with simple operator interface, disposable single-use extracorporeal blood circuit, venous access that can provide from 10 to 40 milli per minute of blood. How much and how fast? Setting of the appropriate fluid removal rate to not exceed the intravascular refilling rate. This is crucial to minimize the risk of hypovolemia, hypotension, transient renal hypoperfusion, transient decrease in the GFR, decrease in creatinine and arrhythmia production. How can you do this? Simply, you can monitor periodically the systolic blood pressure and setting specific limits that would warrant a reduction in the fluid removal rate. Systolic blood pressure is your guide. How much and how fast? As we tell you, there's two rates: the rate of fluid removed from the intravascular space, which is the ultrafiltrate rate, and the compensatory is the rate of fluid entering the intravascular space, which is called plasma refill rate. Therefore, the ultrafiltrate rate should be equal or less than the plasma refill rate. What are the advantages over the loop diuretics? Complete control over rate and the total volume of fluid removed. Ultrafiltration different from diuretics in that it removes isotonic fluid and therefore removes the greatest possible amount of sodium per unit of fluid withdrawn, not associated with electrolyte depletion. It may decrease or eliminate the neurohormonal activation and reduce the length of stay and the rate of rehospitalization. How to set? This is a simple key. Setting for removal rate from 10 up to 500 ml per hour in increments of 10 ml per hour, and the default is 0. With these features, users can set the fluid removal rate that is best for each individual patient. It should be well anticoagulated with ACT 180 to 20 seconds. And the choosing of venous access, we need 2 catheters or lumens are needed. The required blood fluid range from 10 to 40 ml per minute. Many venous access sites and types of catheters can be used. The exact choice is determined by the prescribing physician. And thanks for attention.